Well, welcome to today's webinar. My guest today is Barbara Carnes, who's been one of hospice care's best known and most respected experts for more than 30 years. Our topic is important, far-reaching, and controversial. Pain, morphine, and dying, considering pain management at the end of life. Today's webinar is a conversation, not a lecture. We'll be benefiting from the frank perspective and the real experiences of a renowned hospice nurse who has been at the bedside of hundreds of people during the dying process. If you're ready to have your assumptions challenged, to be inspired, and to deepen your understanding of effective pain management, this is the webinar for you. First, a few tips that will hope you have a great experience today. The webinar audio comes through your computer speakers. If you have trouble hearing us at any time, just click on the chat icon and send us a message. The support person is monitoring the chat and is available to help you. That chat icon is in the lower left corner of your screen, and it opens a window where you can type messages. This is the best way to communicate with us. If you have a problem or a question, we'll answer questions as time permits to the end of the webinar. And I know many of you like to have the webinar material for future reference and for note-taking in the session. So we sent an email to all registrants this morning with a link to download those materials. It's a PDF of the slides you'll see today. Check your inbox. If for any reason you didn't receive that email, don't worry, we'll send it again. Or you can download the slides right now at wellsky.com/slides. But note, because today's presentation is a conversation, there may be some times that we vary from the exact order of the slides you downloaded, but we will cover all of them. And finally, today's presentation is free for you because it's paid for by WellSky, software and services to realize care's potential. WellSky is a technology company that powers care in every setting, from the hospital to the home, from healthcare practices and facilities to community. We serve more than 10,000 customer organizations, the largest home health and hospice agencies, hospital systems, blood banks and labs, government and human service agencies, and more. WellSky Hospice Software, formerly known as Kinder Hospice, is unique in the field because it was designed in collaboration with hospital professionals. We worked closely with successful hospices to develop a software that would meet the unique challenges and communication needs of hospice care. By incorporating intake, scheduling, point of care, QA, claims, reporting, and more into one easy-to-use web-based software, WellSky has become the leading technology partner for hospices across the USA. We help hospices solve challenges, enhance collaboration for growth, and improve outcomes. If your agency isn't already using our software, request a demo today. You can do that anytime at wellsky.com/demo. Or during this webinar, just use the chat window and type in, "I'd like a demo," or "I'd like more info," and we'll get in touch with you right away to schedule that. More than 30 years ago, there was little to no information for families about the dying process. One woman changed that, and she's our guest today, Barbara Carnes. Barbara is an internationally respected speaker, educator, author, and thought leader on matters at the end of life. She has dedicated almost 40 years to the education and care and comfort of dying people and their loved ones. She's been a home health and hospice executive director, clinical supervisor, and a staff nurse. And in 1986, she wrote Gone from My Sight, the first of its kind, an educational booklet for families about the dying experience. This is the little blue book that 20 million copies later is still the most widely used handout in hospice care. Through Gone from My Sight, numerous other books, speaking engagements, and her terrific email newsletter, Barbara has become the go-to expert who healthcare professionals look to teach them how to neutralize fear and how to explain the dying process to families. I'm honored to welcome Barbara Carnes. Hi, Barbara.
Hi there. How are you today?
I'm doing great. Thanks for being with us.
Oh, you're welcome. I have to tell you that I'm nervous. Anytime I speak to a lot of people, I get real scared. So just know that I'm nervous. And how am I going to live up to all that introduction? Holy smoke. So I want everyone to really know that I am here to give you something to think about. You may not agree with everything that I have to say, but I want you to think about it. Okay, that's my whole focus today.
Yeah, something to think about. So I'd like to start today's session by reading something that you wrote that really made an impression on me. And it's really short. You wrote, "We are born, we experience, and then we die. All the space between birth and death is living. Dying is the final experience of life. I want to help people within the confines of their bodies and disease processes to have quality in that final act of living." So I'll tell you, Barbara, that speaks to me because it puts into words a powerful mission for hospice care that is also a mission for pain management in hospice care. And I was wondering, tell us, why is pain management an important topic to you?
I think the main thing is that it's so misunderstood that our working with end of life, our key focus has to be education. We have to educate our families, we have to educate the community, and we even have to educate medical healthcare professionals, because end of life care and pain management is different than the care, medical care, health care of someone who's going to get better. We in this industry know that, but most people don't. And unless we educate everyone in end of life care and its difference, our work will be judged on how people get better. And we can't succeed in living, well, living is important. We can't succeed in measuring up to the standards of someone who they're not. Our patients aren't going to get better. And so we have to educate everyone on the difference, and pain management fits into that because there's so much misunderstanding on how to keep people comfortable. Misunderstanding not just in the community, but among healthcare professionals and among hospice workers. There's controversy and misunderstandings there as well.
So, your emphasis there on education raises a question for me of when does that education begin? And is that education for family and caregivers only, or is the patient involved, assuming the patient is still alert and engaged?
Well, you know, it used to be that hospice got their referrals when the patient was alert and trying to figure out how to live, but the best that they could. But now hospice gets their referrals when the patient is really in labor, you know, those weeks to days to hours before death. And we can't do much for the patient at that time. We can deal with pain management if that's an issue. We can do mouth care, positioning, Foley care. But as far as interacting with them and educating them, they're too removed from their body. so that leaves us really doing crisis intervention with the family and significant others, because unfortunately, most people are tuned in to getting fixed until the last minute, and no one has really addressed end of life with them. So hospice comes in for their initial visit, and what happens is we're doing crisis intervention because we're explaining what's happening now with our loved one, and that yes, death is coming. And so comfort management begins, comfort education begins on the very first initial visit.
You know, hospice takes an interdisciplinary team approach, sort of a team-oriented approach to care. Are there roles in the pain management process for members of the team beyond nurses?
Observation. I think anyone who is in the home, whether it's the chaplain, the social worker, the home health aide, the volunteers, our job is to observe what's happening in that home or in that room, wherever that patient is. We need to report back to the nurse who's going to work with the medical director and the patient's physician. But it takes many, many eyes to be aware of what is happening with that patient. So it takes a lot of teamwork, and we have to recognize it is not just the nurse that is responsible for looking and being aware and managing the comfort level.
Yeah, that's a lot of eyes and a lot of communicating. If the team isn't communicating, that process isn't going to be functional.
Well, and with how visits are, how nursing visits are, in that, you know, it used to be that nurses were with the patients more than they are today, and that's a whole nother webinar. But with the fewer visits, then the eyes and ears of the rest of the team becomes even more important.
Barbara, is dying painful? You know, that seems like it's such a simple question, but it's pretty profound.
I do not believe that dying is painful. And I think we, the watchers, interpret it, what we see as occurring, as painful. But the person that's dying, they're so removed from their physical body that it's their perception is kind of like if you were having a dream and you were far, you hear in the distance, you hear everything from afar, but you're so removed from your body and from this physical realm that you don't experience the body in the same way that a healthy body experiences their body. So dying is not painful. Disease is very, very painful. Disease causes pain. So what you have to look at when you, on that very first visit, is what is the person's disease history that has brought them to this place of coming on to the hospice program, to have entered the dying process. What's their disease history? There are a lot of diseases out there that don't cause pain. And if pain was not a part of the disease process, then there isn't going to be pain just because the person is in the labor of dying. But there's also a lot of diseases out there that causes pain. And if pain has been part of the disease history, then you are going to do everything possible to get that person comfortable. And when someone says to me, oh, we've done everything and we can't get this person comfortable, then I believe you haven't done everything. There is no reason today for anyone to die in pain. But we have to get over the hurdle that dying is painful, because it isn't. And now we go back to education. We educate the family, the significant others, the watchers on what is unfolding in front of them and what this person is doing and why this isn't painful.
Could you give us an example or two of some disease conditions that are particularly associated with pain at end of life?
Cancer of the bone. Oh, that's so hard. That's so painful, and it's very, very hard to manage. This is the point where you have to use several medications and sometimes radiation. I mean, there's all different things we can do, but that's one that really stands out for me as far as being painful.
Mm-hmm. As the body is getting nearer to death and kind of starting to shut down, do you have to change dosages as you kind of, as the patient nears end of life?
Even before they enter the actual dying process or the actual labor of dying, pain management, number one, is individual. There's no, one dosage fits all. If I have a headache, I can take 2 ibuprofen and you can take 2 ibuprofen, and it's probably going to make the headache go away. Pain management doesn't work like that. It's totally individualized to each person. And you can have someone very, very comfortable on a certain milligrams of whatever pain medicine you're using, and they wake up the next morning and, oh my gosh, everything's out of control. Well, you've got tumors growing, you've got pushing on nerves and muscles, and you've got a body that is in total disarray. And so there is no one size fits all, and you will probably have to, over the course of the person's illness, increase their pain management gradually. And that's where your observation comes in. That's where you notice, this worked for him last week, it's not working now, so we're going to increase. That's very, very much a part of end-of-life pain management. Then you get to the hours to days before death, and then you have a new function or lack of function that kicks in, and that is the body shutting down, and your circulation isn't normal, your fluid intake, outtake, kidneys, all of this, the body isn't working, circulating properly, so it's not getting the medication throughout the body in a normal, and I put normal in quotes, in a normal fashion. And so again, you have to observe and assess and figure out how you're going to keep this person comfortable.
Mm-hmm. Could you talk a bit about restlessness and agitation? So often families see this and it's so alarming and they assume that they're seeing pain. Is that what they're seeing?
I don't think it, well, let's say it can be restlessness, agitation, can be, and this is where you look at your disease history. And if pain wasn't an issue, then the agitation and restlessness is probably not due to pain. Agitation and restlessness is it's a part of the normal, natural labor that we go through. It's one of the key signs that tell me that a person has entered labor, that they have 1 to 3 weeks to live, is that picking of the air and the clothes, and you just, you can't get them settled. That's very much a part of the normal way that a person dies. And so again, we need to educate our families into what this restlessness and agitation is significant of. It's almost like up to this point, up to the 1 to 3 weeks before death, a person who is ill and is dying in that process. In the months before death, they can talk about the idea that the doctors have said they can't be fixed. They can plan their funeral. They can talk about dying, but they really don't believe it. In the core of their being, they don't believe it. When labor starts, something inside the person that says, my God, it's true. They were right. I'm going to die. And when that realization occurs, that's when I think labor begins. And part of the restlessness on an unconscious level is if I lay down and close my eyes, I may never open them again. And they're right, they may not. And that restlessness, that agitation is a part of the struggle, the fighting, the coming to terms with, this is my final act of living. This is what's happening. All of this is on an internal, unconscious level. If you said to them, are you afraid you're dying right now? They wouldn't even know what you were talking about. In that 1 to 3 weeks, when the agitation and the restlessness becomes paramount, that is a part of dying.
Well, there's a lot of well-deserved attention being placed now on opioid abuse and addiction. And I follow your end-of-life care and bereavement Facebook group. And I know you hear from family members who describe situations where, let's say, their mom was on hospice, she was administered morphine, and 20 minutes later she had died. Does morphine hasten death? Did morphine kill mom?
This is probably one of the key situations, the key misunderstandings that family members have when their loved ones die and narcotics are involved. And I think part of that is our lack of educating the family about morphine, about narcotics, because it's everywhere you turn, on the news, on PBS, it's the opioid addiction problem. And so we're all afraid of narcotics. But we in hospice and working with end of life, it is our job as part of administering pain management and using narcotics is to educate the family in its use. And in that we're not overdosing, we're not addicting, and yet that, to me, when I have a family tell me that, and they carry that with them forever, and that complicates their grief forever, because they think they're responsible for letting hospice kill their mom. So we have to educate. If a person is on high doses, even low doses of a narcotic, and they have been getting it on a regular basis, and they get their under the tongue, or they're in the rectum, their suppository of a narcotic, and 20 minutes later, mom died. That narcotic has gotten nowhere. It's still in the rectum. It's still under their tongue, probably, because there's no the circulation is almost stopping. The heart is not moving that narcotic through the bloodstream. And so it has not had even time to do anything, let alone stop the person's heart and respiration. And yet it is up to us to teach the family how that works. And not only to teach them, but to make sure they understand what we are teaching them. Because it isn't enough for the nurse to go in and explain the medication. And here's how often you give it. Here's why you're giving it. But you want them to give it back to you. Tell me what I said. What did you understand? Because I think there's a huge disconnect there, where we who are teaching think, well, I told them, and now look what they believe. Did they really hear you? Did they really understand what you were saying? I think that's key.
Mm-hmm. Yeah, I've heard people describe that aspect of ensuring that another person has understood what they've been told by asking that person to sort of role play. You know, if you were explaining this to your brother who's not here, how would you explain what I just shared with you? Does that sort of approach make sense to you to use in that sort of situation?
Absolutely. Then you know. I mean, we have to use tools to see if they understand what we're saying. And role play is a great thing. When you said that, one of the things that immediately popped into my head is the time factor that our nurses, all of our hospice professionals are under. You know, and I hate to be the old lady that's saying in my day, but I'm going to say it. When I started and learned all of this, I didn't have the time constraint that you all have today, with all the regulations, with all the patient loads. You know, I could go in and stay hours if I felt that was necessary, to support, to guide, to teach, to observe. You know, I can't tell you how many nights I slept on the floor, but you can't do that today. And I think in our heavy workload, we oftentimes skip some important areas. And that is, you know, we look at, well, I told them, I taught them how to use it, and now I'm going on to the next patient. So we feel pressured by the limited time constraints that we have to spend with our patients and families. And that's a really sad state of affairs, but that's what's happening.
Yeah. Do all hospice patients at one time or another need pain medication?
No, there's a lot of people who are dying that do not have pain, And so if they don't have pain, it is inappropriate to give them pain medicine. Why would you do that? Again, I think some of us know that. Some of us professionals know that. But we succumb, if that's the word to use, to the pressure of the family's interpretation that mom is in pain. That falls back on education, on our taking the time to teach the family what's happening and why this is not painful. You know, if restlessness and agitation reaches a place where you think the person's going to hurt themselves, then of course you're going to do Ativan or Haldol or something to calm them down. That doesn't mean you have to bring in pain medicine for the agitation. You're going to deal with a narcotic and pain medicine if there is pain. And I have to underline that because we're reaching a place where some of us have it in our head that dying is painful, and therefore just across the board we're going to give a narcotic in the last hours to days of life. And that to me is a misuse of narcotics.
Mm-hmm. Education has been such a theme already in today's conversation. I'm wondering, how do you balance informing a family member about pain and pain medication without burdening them with a perceived choice that they have to make, and the fear, the terror that they would have about making the wrong decision regarding their loved one care? How do you balance that?
I don't think it's the family. They don't have the knowledge to dictate how we take care of their loved one. And yet I see that happening. You know, I see moms in pain and I want you to do something about it. I don't believe we should become intimidated as healthcare professionals by requests that are based on ignorance. I know that sounds harsh, but we, in our community, using our communication skills, our people skills, we're going to try and get to educate the family why what they're requesting is not appropriate. Okay, I'm going to stop there.
That makes a lot of sense. Let's talk about injections and IV medications. What's the role, if there is one, for injections and IV as death approaches?
I've come to the conclusion that a lot of it depends upon access and where the patient is. If they're in a hospital, then chances are they're going to get an IV and they're going to get pain medicine, probably whether they need it or not, in an IV, because that's what hospitals do. I don't think anymore you can get in a hospital or out of it without getting an IV. And so that's how they think of administrating medicine. A lot of acute care, not a lot, most acute care facilities, their concentration, what they're trained in, is fixing people, is getting them better and getting them out and to return to normal life and activity. End of life care is different, but acute care facilities don't really understand end-of-life care. And so you see in those facilities what I consider inappropriate end-of-life pain management. In the home and in hospice houses and even in nursing facilities, IVs aren't as readily available. They aren't considered as this is our next step. And so using oral or topical, I love topical. We had a pharmacy that compounded up one as long as you put gloves on, and had the family put gloves on when you rubbed it on the skin. It was great. We loved doing that. Sublingual, rectal, that same pharmacy made us suppositories. You don't have to be as invasive as IVs are. And IVs put, and if you have it in the home, you put an additional responsibility on the caregiver, on the family, when they're already way overstressed. And you just don't need to. Plus, I'm going to throw this out. You're hydrating. IVs, if you hook one up and you're going to put medicine, generally, if it's, you know, a liter or whatever, you're giving them more fluid. And hydration is what you don't want at end of life. Dehydration is part of the natural way a person dies. And if, you know, you want those electrolytes to get out of balance, you're not creating it, you're allowing the normal natural dying process to unfold. By not giving IV fluid, you're just adding to the congestion and the discomfort that the person's going to experience.
Right. What about fentanyl patches?
Oh, I was there in the field when fentanyl patches first came out. And oh, it was just this big, great solution to pain management. Well, it is not for end of life. And the reason it isn't is because you can't play with it. And the whole key to end of life pain management is you have to play consistently with the dosage. You're going to start out low and you're going to gradually increase until the person reaches a comfort level. Then you're going to stay up at playing until they, you know, and that can be days, weeks, it can be months that they're just great. And then all of a sudden you're going to have to increase. And so the fentanyl patch, you can't play with it. And that's why I see it maybe in the months before death. You can use it carefully, but in the way we get hospice patients today, there's no place for fentanyl. They don't live long enough for us to figure out what dosage they really need to be comfortable.
Right. A question has come in from the audience, but because it's an interesting one. The person asks, sometimes patients towards the end of life will stop eating and they won't have a bowel movement for a week or more. And it becomes painful for them if it's not addressed. Could you talk about how to handle that situation? Because it's relevant to pain management, but it's not like giving someone morphine.
Oh, but it is like giving someone morphine, actually, because the morphine probably caused it in the first place. Mm-hmm. Automatically, if you give someone a narcotic, you automatically also give them laxatives. And again, you're gonna have to play with it to see, because everybody's body is different. But you've got a narcotic and laxative go hand in hand. And even if the person is not eating, their body is still making poop. You know, it just is. And we have to get it out. And the longer you wait, the more comfort you're creating for the patient, to where you're having to digitally. And that just really is very, very hurtful. So when you start a pain management protocol, part of that protocol is a narcotic.
So they really need to go kind of hand in hand.
Yes, there's no, I can't, well, I won't say never, because there's always exceptions to the rule. But generally speaking, narcotic and laxatives must be given to them.
What about comfort packs? Have they, how has comfort packs affected pain management in hospitals?
Now, this is purely Barbara, so take it for whatever you want to. I think that comfort packs in the home for every patient simply makes it easier to give and use those medications, whether it's appropriate or not. And I say whether it's appropriate or not, and I'm going to qualify that because there are, and I'm going out on a limb, there are people working in end of life that really don't understand end of life. And they are dealing with it in the same manner that you work with someone who's going to get better. And as much as we train and educate our hospice people, a lot starts at the top with the physicians, and it's just a gray area where lack of education is there. And I think we make it way too convenient having those medications there in the home. And I know people will argue that with me, but that's okay.
Patients' advanced directives come into play in pain management, like for example, and I don't know if you've ever seen something like this, if a patient puts a statement into their advanced directive like, medicate me as much as possible if pain is part of my disease.
And that's very appropriate. That doesn't, they're not saying overdose me. They're saying if I have pain, treat it. And of course, that's what we want to do. So that's very much honoring. And I don't see where that goes against anything in an advanced directive. That just seems logical to me that you would put that in your advanced directive. The bigger issue that I often find with advanced directives is that the advanced directives say things the patient doesn't want and the family and the medical community thinks they ought to have it. That is where the bigger conflict comes in, and that really doesn't have anything to do with pain management.
Yeah. One thing that strikes me in the kind of a running theme in everything that you've said so far is that end-of-life pain management is not a one plan fits everybody kind of a thing. It's very individualized. Am I on target there?
Absolutely. is, you know, it goes back to 2 aspirins for a headache. The first thing you do with end of life pain management, no, the first thing you do with disease management before end of life ever gets into the picture, with disease pain management, you're using your pain scale, you know, 0 to 10. Where are you? And then we work to get to a comfort level. And as death approaches, again, observe and then act on what you observe. There is no solve for end of life pain management or really any kind of comfort management. And yet our medical model, which hospice is becoming more and more absorbed into the medical model, our medical model operates on formulas, on if we do ABC, then D will follow that, or 2 plus 2 is 4. In end of life, 2 plus 2 could equal 55. You know, there is no standard anything in end of life. As medical professionals, we feel more comfortable with standardized everything. And that's what's happening with our Medicare regs, is they're standardizing how our care should be, and they don't seem to understand that there is no standard to dying. There's a process, and we can learn from that process, and we can watch, but there's no one size fits all in end of life. And I want to say one of my favorite things, which has to do with pain medicine management, but I really, really feel strongly that our medical model treats diseases that people have. Hospice philosophy is to treat people that happen to have diseases. Our focus is on people, not just the patient that's dying, but the family, the caregiver, the significant others. And I don't want us to lose focus of that we take care of people. And people are not 2 plus 2 equals 4. There's no standard for any people. That's what I loved about hospice. Standing on the porch before I rang the doorbell, and I'd say, oh dear God, I seek to heal, not hurt. Because I never knew what I was going to see and have to deal with on the other side of that door. And I loved that.
Let's get into some questions from the audience. I've got a number that have come in that I've got listed in front of me right now. Are there non-medication ways of dealing with pain that you've seen be effective for patients?
Absolutely. In fact, it pleases me so much to see that hospices are using massage therapists, harp music. You know, you get your musical therapist in there. Reiki is also good. Some of your alternative hands-on. The key to a gentle death is to relax. And so anything that we can do to relax a person in their dying process is going to help them have a gentler experience and a gentler journey. and however we can come up with to help them relax. I crawled, and I suppose Medicare wouldn't like this either, but I crawled into bed with patients and just held them in my arms because they were scared and they just needed some comfort, some of that human warmth. That's comfort care.
Yeah, for sure. I mean, the only person I've been with as she died was my grandmother, my maternal grandmother, and she wanted the very same thing. She wanted me to lay down in bed beside her, and I did, and it seemed to really bring her comfort, just that closeness. In your writings, Barbara, you've described the labor of dying, describing it like the struggle of a chick to break through and escape the egg. Could you talk about that a little bit?
I will. I love this story, and I started off telling this story about the little chicken with children to help them understand what dying was like. And then I realized that this story is so helps us understand what a person is doing when they're dying. Look at the little chick who works and works and works and works and pecks and pecks and pecks and pecks and works so hard to get out of its shell. Our physical body, that's all it is. It's just a shell. There's a driver to this shell, and the driver is trying to get out of it. And so it's working. The agitation, the breathing changes, the lack of circulation, the kidneys shutting down, all of those things that occur as we leave our body is just the work of us getting out of it. And some of us, just like some little chicks, can get out of their shell easier than other chicks. So it is with us. If some of us can get out of our bodies easier than others.
Mm-hmm. That's such a metaphor for what's going on. I really relate to that. Barbara, thank you so much for today's talk. It's been interesting, fascinating, informative. Thank you.
Thank you for asking me. And as scared as I was, I feel really good about how we did. I think we did good.
Good. I agree. Well, Barbara, thanks for today and for all your contributions in helping us provide great end-of-life care to patients. We really appreciate it. I know that we have a few questions that we haven't had time to respond to those in written form and send those out to everybody here in the next few days. I also want to tell everyone, check out Barbara's website and her newsletter. You can go to bkbooks.com. I subscribe to this, and I get so much of the articles that she publishes through the newsletter. You need to know that more hospice providers use our software.
It's over. I don't think that'd be very well done. I really care about